Welcome to the second hour of Kenya's biggest conversation. We are here until 10 a.m. and we are live on SpiceFM. We are also live online, SpiceFM KE, YouTube, Facebook, Twitter, www.spicefm.co.ke. Before we introduce our next guest, who needs no introduction, the day's proverb.
A stranger does not skin a goat given as a fine in a chief's camp.
A stranger does not skin a goat. Go on. The rest were too many words.
Yes, given as a fine in a chief's camp. Meaning, you can skin a goat in a chief's camp,
but not the fine. Not the one given as a fine.
And not a stranger.
Yeah.
Meaning, it isn't unusual for you to see such an occurrence. But it can't be a stranger. But more so, it can't be a goat that is given as a fine.
There you go.
Okay. Our guest this hour is Dr. Mwangangi, the Chief Administrative Secretary in the Ministry of Health. Remember, we said this week, the 7 to 8 hour, we are celebrating five women who are making big moves in public service. And we had Dr. Kizi Shako on Monday. We had Kithinji yesterday, Emma Kithinji yesterday. Now today we have Dr. Mwangangi. Welcome to the Situation Room.
Thank you. Happy to be here.
It's good to see you again, Dr. Mwangangi.
Yeah, it's. I mean, the last time we met, that was during the thick of the COVID-19 pandemic last year, which we're still dealing with.
Yep.
So happy to be here today and share with everyone what we're doing in terms of women in public service and all the excellent women, big moves, big boss moves that they're making in the public sector.
Indeed, big boss moves. Eh? Good stuff.
Yeah.
It's also good to see you relaxed. I mean, the last time you were here, we were also all
everyone was
nervy.
high-strung.
I mean, we were just wondering, so what's happening? When are we going to die? So
Yeah.
am I going to die at night or during the day? I mean, who do I need to blame for my death? And all those things.
Well, we're still in that space in the sense of the pandemic is not over.
Yeah, of course.
But a lot has changed since, last year, March, April. You all know we have the vaccine. I didn't ask you all if you've been vaccinated, but I'm assuming, seeing as you're all sitting in this room,
Yes,
and
we're
some
waiting-
people look like they're over
booster.
60, they have been vaccinated.
I need to assist you with that.
That guy right there, he looks like he's over 60. He's probably been vaccinated. So so a lot has happened in the COVID fight, right? We have vaccines.
Yep.
That's the biggest silver bullet that we have right now. And the country is in a good spot because we now have at least close to 6 million doses in stock.
Right.
So hoping to get to our 10 million target in December.
There's a target of 5.8 million in
Yes.
the next 14 days.
Yes.
Now, looking at the latest statistics from the ministry yesterday, 3.9 what?
3.935.
That's where we are at. And we think we will make the target. So what's happening is in a day we started with 10,000, got to 50,000. We had a good week where we managed to get to 90,000 a day, people vaccinated. So what we've been doing, if you've noticed in the last week, is really pushing what we're calling RRIs in different groups and cohorts. Yesterday, CS Muthui Kagwe was in Mathare Hospital. So we got all our inpatients vaccinated in Mathare, as well as outpatients, as well as the families of the staff and the staff. Last week, we were in Naivasha, dealing with the prisoners together with CS Matiang'i. So we are on a drive, a rapid results initiative drive to get to that 5.8. 3.9 is not too bad. If you're doing 90 a day, you should be able to get to 5.8. And it's significant because Kenya will be turning 58 very soon. So
Right. Because we're just looking at it. Last week, we had Dr. Willis Akhwale, chair of the vaccine deployment program. And he was telling us, so the target is, if we are to hit that, let's aim at 100,000 a day.
exactly, yeah.
2 million, that at the beginning of the month, it was 2 million. So now that we have 14 days, it's basically
Right.
looking at 1.4 million.
Right.
And I'm looking at this and I'm seeing 1.4 million. We are still off target.
Here's the thing. Cautious enthusiasm.
Okay.
In terms of stocks, we have the vaccines, right? So we have literally most of the platforms available. Moderna, Pfizer, I think you also that we now have the syringes and what we needed to sort of get that going. So I think what you'll see is intensive activity in the next 2 weeks. I'm happy with certain counties who've taken the initiative. Kiambu governor took it upon himself. He's launched an outreach. He's going to people in stages. So I think we'll get to it. Let's wait and see. Perhaps, if we'll be nervous a week too, then you may see all of us out there in the streets trying to get to that 5.8 million. But I think there's good demand. Kenyans are looking for vaccines, so we should be able to get to that 5.8. Yeah.
What are we looking at in terms of there are many questions, and I know that has kind of riddled the whole process before, and I mean we've been able to go past that and already deal with that and say, look, the good vaccine is the available vaccine.
Yeah, that's important.
Right?
That's super important.
Right.
Yeah.
So what are you still dealing with?
I think right now the biggest thing is it's sort of, like a car engine. And no, I'm not an engineer or mechanical engineer. And I really don't like cars. But the thing is, getting all those cogs and wheels working and efficient and agile perhaps is where we are at right now, because we have the doses and we have the staff, right, who've been doing this for a long time, even beyond COVID-19. We've been giving many vaccines, and Kenya is good when it comes to immunization programs.
Yeah.
But then dealing with, should I say, the logistics and the agility that's needed. I'm sure you've all heard of complaints here and there. I went to Mbagathi, I waited for 2 hours, or I went here and, to Mata, and they said there's a stock out.
Yeah.
So it's getting that, well-oiled engine working and all the nuts and bolts greased so that we can get that going. And of course, it's a new sort of space in the sense of it's an adult vaccine. So I think that's the biggest sort of challenge for Kenya. We've always done pediatric vaccines or child immunization vaccines. So we have systems set for that. A mother comes in, she has the booklet, she knows it's a must. But when you deal with adults who you have to, one, of course, nudge towards getting the vaccine because it's protective, it's good public health good, and then number two, then getting the systems and everything going, it's been a challenge. I remember about 3 weeks ago we had the challenge of reporting, right? So facilities were actually consuming their doses, but then in their submissions to us, there's a lag, so meaning we of course cannot push vaccines to them, and of course that then affects Mwananchi when they go to the facility. So it's getting that working.
That I have trouble understanding this. I can understand the issue of, okay, we're dealing with adults now.
Yeah.
So adult is hesitancy, is information. But the machine working, this is government.
Right.
Government is a machine.
Right. Oh,
and
yes.
it's always working and it's always moving. So when you get to a point where because to me those are basics, that information, for example, coming back to the headquarters to say we have exhausted or we need more, or just getting the vaccine out of the central location to a facility, those should be basics.
So
those should be things that you
with you.
Put in there and you press the button.
I do agree with you in terms of, if you look at it like the running of an institution or the running of hospitals, of course, government has been in that business since independence. The thing here is with the COVID-19 vaccine, there's so many stakeholders, so many new players in the game. And what's interesting is that now we're dealing with almost 4 vaccine platforms, right? So if you take your child to the facility, it's BCG. BCG is clear. It's BCG. We're running with BCG. It's done.
Okay.
Right now, we have people dealing with Sinopharm. We have people dealing with Moderna, Pfizer, and AstraZeneca. So in terms of the players, it's actually a new space, even for our healthcare workers. And, for those kinks to be sorted out, remember, not just public facilities, but also private facilities but also faith-based facilities. And one of the interesting things that you may not know is that if you look at the paradigm of all the health ownership facilities that we have in the country, now is the time where we are having actually most of all those facilities reporting into a single database. It's actually a new sort of what we're calling a silver lining of COVID. It's making us demand data from each and every health facility that is administering the vaccine or testing when it comes to COVID-19. So a few kinks here, but I'm more hopeful, especially being in the sector for 10 years, for us to be able to pull this off where we are right now, and how we've done it. Yes, it's not 100%, but I think there's need to appreciate, all the workers and everyone who's made this possible to date.
You're in the engine room, obviously, so you can see the things that are happening, and you can see this is actually a big thing compared to yesterday when that particular cog wasn't moving at all. So you can see that. And when you say that, you have that optimism.
Yeah.
All right, we'll give you that.
Yeah.
The other issue that we keep asking ourselves on a daily basis, we start the show with tracking COVID-19 numbers.
Yes.
And then we have now the figures from the ministry. Yesterday, X number of samples, X tested positive, X number of deaths reported. These deaths are coming from 3 months, 4 months ago. And the one thing that we keep saying here is, How is it that we can be reporting a COVID death 4 months down the road?
Yeah. Yeah.
Nobody gets buried in this country without the government knowing.
Right. So, I mean, fantastic question. And this is a question that's actually been discussed intensely within the Ministry of Health. And there's a team. So there's a data team, a HIS team, we call them, who are trying to deal with those issues. So let's get some context here. Mortality reporting the world over is actually a challenge for many countries. There was a time Kenya was actually, struggling when it came to reporting of births and deaths, because it starts way beyond the Ministry of Health into, the Ministry of Interior and Coordination when it comes to registration of births and deaths. This is what we call civil vital statistics. We had a forum where we sat with Africa CDC and WHO, and we were discussing, what is the true mortality when it comes to COVID-19, and do we have any excess mortality? So deaths that are not accounted for with any other cause, and perhaps then can we attribute those deaths to COVID-19? And we started an assessment in Kenya, and this was started also in all other countries. So in the Africa CDC, AU Union countries, and also abroad. Interesting fact, all countries, including the UK, including America, have come forward and stated that they do have challenges when it comes to accounting for deaths for COVID-19. And it is because of the processes of how you do that. For example, it's important to note most deaths that are captured in the system are deaths that happen perhaps in the healthcare setting, so in the hospital. Deaths that happen at home, deaths that happen en route even to hospitals. Sometimes we have missing data of those matrices. Another important thing is perhaps even the deaths that are captured in a hospital require further auditing and interrogation. So I could be a diabetic hypertensive who then got COVID, who then got a fracture, who then fell from a balcony. And we're still in the space where our medics and the systems are trying to code what is called disease coding and causes of death. So it's a lot of, let me say, a lot of technical jargon. You can see me rattling on behind there. There's a lot that goes on in the background.
It's work in progress.
To fight, not really work in progress, but let me say a challenge in global recording of mortalities. So it's beyond Kenya. It's something that's happening across the world. And essentially, the idea is, how do we code better for diseases? How do we code better for death? How do we code better for also morbidity diseases? And it affects systems.
I hear you also saying that the cause of death for a particular individual could be multiple.
So that's the thing.
Right?
So, and that's what we call disease coding. So, and it's actually a system. So how you then pick out the final end cause of death is a little bit of a challenge, that I will tell you. We've also done what we're calling audits in our morgues to be able to see, so is it commensurate with the people who are coming into hospital? Is it commensurate with people who are dying at home? And therefore then we have verbal autopsies by the chiefs. And so it's not easy.
And how do we do it currently? How do we determine the number of deaths in the country?
So what happens is that there's an aggregation process. So we have the Ministry of Health, we have deaths that happen at home through chiefs, deaths that happen outside of home through the police infrastructure, and then we have then deaths that happen, perhaps people who are brought directly into a morgue. And so there's an aggregation process. And the worst thing, what I'm trying to explain to you is that if you're found in a morgue, what exactly killed you?
Right.
A postmortem is needed. Not everyone goes through a postmortem sort of service. So it's a bit of a messy space in terms of trying to aggregate it, but there's been gains. We now have support through the World Bank to look at our civil vital statistics, and government as well. There's a lot of work in the background in trying to harmonize all this with Huduma number and IDs, and sort of layering the whole system so that we're able to get the kinks working.
But with the approximation, give or take, how close are we to the actual numbers?
For sure, when we've been reporting, for sure, that is not the final accurate statistic in terms of our deaths. That one we agree with you. How close are we? It depends on when we are in the wave.
50, 60?
So I don't have a number right now or a proportion, but what I can tell you is the last assessment we did of excess mortalities, it showed that we'd missed the target and we actually had more deaths. And that was during the fourth wave, when we were actually having a lot of admissions and a lot of people in ICU. Is that metrics of the fourth wave the same as the third wave? No. So it depends on what's going on. Delta was there for the fourth wave before Delta wasn't, and so there were fewer deaths. So it's a moving target. it's not target because you don't want people to die, but it's a moving statistic, right? And I can see you giggling, but the process of actually accounting for those deaths is not as easy or as straightforward as people may think.
Right. Even as we talk about COVID, then we look at a broader situation of the health system in general in the country. COVID split wide open the system. And then we were able to see, all right, probably things that the system or the healthcare system was doing well. And then unfortunately, many things in which there were failures.
That's true.
What are some of the things that you saw as failures which probably need some attention?
I mean, that's a good question. There's always this statement where everyone, I've seen all the journalists saying, COVID has exposed the underbelly of the health system. And I think what we feel particularly in the Ministry of Health is that, it was a good push. It was a good spotlight on the health sector. It was a needed spotlight on the health sector. I think for us, if you look at the different, what we call the building blocks of a health sector, sort of the, should I say, pieces that put it all together, the first most critical thing perhaps is the role of the healthcare worker. I think COVID made it absolutely clear and certain to government, to ministry, to partners that we do need to invest in our human resources. And this doesn't mean that we were not aware, but perhaps in the COVID-19 situation, there was clearly a stretching of healthcare workers. And this went all the way. So I think you've all heard of community healthcare workers and volunteers. Again, their need was determined. I think you've all heard of anesthetists. I think for the first time, everyone was talking about, the super specialties, the ICU specialists. Again, a need for that was determined. And if I look back, 2019, before COVID, where we were, particularly in the ministry, was trying to invest towards UHC. So trying to get the Big Four agenda going and the Universal Health Coverage Program going. And when we were trying to design that program, I remember people saying, we need to account for healthcare workers, we need to put some money and ensure we hire some healthcare workers. And we did, and that was budgeted for. And it's interesting, in 2020, around March, April, those resources were then converted towards what we are calling the COVID staff. I'm sure you've seen them in the counties. We had interns coming in, much like the Kazi Mtani program. We had a bunch of about 1,000 plus interns coming in. And then we had 3-year contracts for medical officers and nurses. And what I'm always happy about, for the first time, psychologists in the Ministry of Health. Before COVID, that was a cadre that was not recognized in the Ministry of Health. Now they're recognized because of mental health issues. So some good small steps. Are we there yet? No, we are not, definitely, when it comes to healthcare workers. Are there future plans to invest more in those spaces? Yes. I think you've all seen us trying to make different moves here and there to get more people employed at the counties, in national government, and sort of tap into the unutilized resource of healthcare workers who are there. There are many unemployed nurses and doctors and the whole cadres of scheme, that are there. So healthcare workers, big lesson there. We need to put in more of them on ground, boots on ground, and invest in that space.
Second block.
Sorry, Eric.
Just finish the blocks there.
So the blocks, right. So this is like the ABCs of public health. So we have healthcare workers, and then we have what they call health infrastructure. So the brick and mortar. And I think for that, we were good. Through devolution, the past 7 years, counties have really put up health facilities. If you look back to your county, and I'm talking about the brick and mortar, you'll notice most governors invested, and we have health facilities available. When we look at, there's a matrix which measures health facility sort of density, and Kenya has met that target. So in terms of brick and mortar, we have it. Inside now the health facility, beyond the brick and mortar, a few challenges. So through COVID, a positive, and I'll keep sort of comparing for you and sort of trying to contrast for you. Positive, huge investments in lab infrastructure. Before COVID, so many counties were not able to do PCR testing, which is a background of not just COVID testing, but HIV testing and lots of other diseases. Right now, most counties more or less are able to do PCR testing. On the flip side, again, we noticed challenges when it comes to commodities, challenges when it comes to supply chain. I was talking to an old woman and I was asking her, have you been able to go to the facility and get what you need? It was at a health center, and she said, mimi natafuta daktari na mimi natafuta dawa. So for most Kenyans, when they're walking into the health facility, what they're looking for is that there'll be a doctor and the drugs will be there. In the drug space, we're still working on that, trying to improve that space, trying to make sure those commodities and supplies are available. if I scored us, that's an area that needs improvement, and we are working on it.
What makes the commodities not available?
So again, one, of course, the basics of it is you need to resource commodities. You need to ensure that they're there. Kenya has been able to put in place what we call an essential medicines list, and this is actually a very crucial tool, much like, and I want to compare it, I want to see what I can compare it to. Perhaps maybe you'd say close to almost a constitution when it comes to managing with diseases and morbidity. What countries have done is to come up with a way of cataloging what the most essential medicines are, the drugs that are needed at different levels of care that you can't live without. Through science, we have many drugs coming out. Through lots of technology advancements, many drugs coming out. All of them very expensive. The R&D process is very expensive, and that's another lesson we learned during COVID. Investments in research and development are important in Kenya, and so you've come to learn that. How do we ensure this list, this huge catalog of medicines and drugs, are available always? One, the money has to be there, but two, what you were asking me before about accounting for debts. Is the IT system, are we able to predict our consumption? Are we able to predict our future needs when it comes to paracetamol? And to do this, I have to aggregate data from each and every health facility, but not just health facility, each and every chemist within the country, not just each chemist, each and every health provider, both public and private.
I have to ask this
Again,
question
not
now.
an easy task.
The Ministry of Health, I'm sure you have a department that deals with costing. Okay?
Yes,
Yeah.
yes, we do. The planning department.
Yes, now-
Yes.
But I specifically want to refer to costing because one of the problems that I think many government ministries have is wastage. Okay? And then every time we talk to people within the counties, health is devolved, and they talk about they used X amount of money for this and the other. Now, people who specialize in costing put a face of reality to all this jargon that laymen like us listen to, and we have no idea whether what you're being told is a fairy tale or whether it's, we don't know.
Yeah.
So let me ask my question. Does the ministry consider it important to invest in such an enterprise? Because,
Completely.
okay.
Completely. I mean, it's not just the ministry, I dare say, but government as a whole. So we actually have a State Department of Planning under the Ministry of Finance in National Treasury. And it's a whole state department, and their work is to work out the figures, not just for today, but for the next 3 years. You've heard of the MTEF cycle, right? The one that determines how governments budget for their resources. So yes, there's that. And what happens is that is then devolved into ministries. So in health, we do have a planning department, and we have our plans in check. But an interesting cog into this is to remember that, like you said, health is devolved. And so then there's need to have, again, these planning departments in all the 47 counties. And we do have them, but working those plans and integrating them together to then be able to have that foresight of the future has been a challenge. Again, work in progress, step by step, getting there. And again, why your question is so important, I've been seeing a lot on social media, Kenyans are asking. I think most recently has been the cost of ICU services. I think we also yesterday, some reports on social media that someone is having to pay 14 million for ICU services for I don't know 50 days or 21 days. And I think 2 weeks before, again, Boniface was talking about the same thing, and we've had a lot of Twitter space discussions as the medical fraternity on the cost of healthcare. One thing that I'm very, should I say, happy about in terms of interventions by government is that together with National Parliament, Waziri has been able to spearhead the process of passing and moving forward the NHIF bill. And that bill, guys, literally is what you call a foundation stone that can really propel a country forward. Why? Because one, it mandates health insurance for all Kenyans. And I saw questions and, comments on, if I can't pay, who's going to pay for me? And when you look at the bill actually ensures that those who cannot pay will get subsidies from government. And we've already gotten our first batch of 1 million Kenyans enrolled who will be getting subsidies for government. Those who can pay, we're trying to put in place mechanisms to ensure that that money is put in within the fund. And then, of course, commensurate to this is that you need to then ensure the fund is more accountable, more transparent, and is agile to be able to provide those services. What that bill will do nearly single-handedly is actually manage the cost of care in Kenya. Because now you will have a payer, that's NHIF, together with all the private medical insurance companies, who are able to sit on the table with providers and determine the costs of care. And I can tell you this has been powerful in Thailand, in all the countries who have gone ahead of us in this space. This led to drastic reductions in the cost of care. And that's what we'll be working on as soon as the bill is enacted and that process is done in terms of legislation. You'll be seeing a lot of change. I can't wait to come back perhaps a year from now and discuss this NHIF bill and where we are, because I believe it's revolutionary. It's the one thing really that's going to set us up in terms of the healthcare system. Number two, we do actually have also a committee that is going to moderate the cost of care. So this is a joint team that will sit with the private sector, the public sector, and all the stakeholders. And for the first time, we'll almost have what we are having when it comes to fuel prices. And no pun intended, but there will be a moderation of the cost of services within the country. This is how much you can charge a cesarean section. This is how much you can charge a knee replacement. And that will be harmonized. Again, costs will come down.
Those are big things.
Big moves.
Kenya's biggest conversation continues in the Situation Room this morning. Eric Latif, Nduoko, C.T. Muga, and Dr. Mercy Mwangangi, Chief Administrative Secretary in the Ministry of Health. Dr. Mwangangi, as we're taking that break, you had you've been beaming, but at that point now, when you're showing the future, looking at projecting into the future, the new NHIF bill, what it proposes, how it proposes to transform health insurance, and then the other work that's happening. I think this is then what would be the building blocks for the universal health coverage. Just tell us a bit about those moves on controlling costs, because as you understand, that's a big issue. Even for NHIF as it operates, if it's paying X times 5 in a private facility and only X in a public facility, that disparity is still huge. If it's going to be harmonized, how are they going to do this?
So like I was saying, I believe, and having engaged in the health sector for a long time and learned from those who've gone before us, one of the biggest things that you have to fix in the sector is how you finance the sector. And this touches on, how do you buy a service in the sector? And most importantly, how do you ensure that service leads to a good health outcome? What we're trying to do with NHIF is perhaps what you say, aggregate the resources that we have in the sector and be able to almost guarantee a healthy, good outcome when you go seek care. And this is sort of a process that needs to take place with all the stakeholders being on the table. And that is why the ministry was pushing really hard for that NHIF bill. If you open it, and I don't have it here with me, one of the biggest things, like I said, is mandating care. We came to learn that in Kenya we have, and I'll give you an example, we have people who own bodas, that's about 60,000 to 80,000, depending on your boda, who then go and buy a cover to insure the boda, but are not paying 500 shillings, i.e. $60, 6,000 shillings for their own healthcare. And this goes on even beyond the boda. I can tell you, we've done assessments to determine that there are people who own a fleet of matatus who do not have NHIF covers. I dare say, even in my own family, I've been able to talk to some people and found out, much to my angst, that there are people who are associated with myself and do not have NHIF covers. So really, I can tell you guys, and I saw a lot of noise when we were going through the bill process, people saying, why is government making this mandatory? One of the principles of setting up what you call a social health insurance fund, which is what many countries have done and done successfully, is that you have to have everyone in the pot. We're talking about UHC. The U in UHC is universality. Universality means everyone in the country. And that's the first step that this bill has done in ensuring that we legislate. It should be mandatory. Now I hear the noise. The second thing is, okay, if it's mandatory and we have close to 36% of Kenyans who are living below, the famous $1.50, how are those guys going to get in? And I can tell you now, there's firm commitment that government will ensure it pays that 6,000 Kenyan shillings for that group. So everyone else then, therefore, has been determined to have ability to be able to pay into NHIF, and there will be mechanisms to ensure we are all in. Now, once we are all in, Another very, very key important thing that we've been hearing a lot and we've experienced ourselves as well is the issue of wastage. He brought it up. How much of those resources that are put together in NHIF, even before, say, our bill, in the past 5 years, if we did a proper audit and we were able to look at the potential wastage and fraud that is there, how much does that lead to? And we've had estimates of close to 30%. 40% of leakage, and that's a lot of money. That's a lot of money. Now, what does this bill propose to do? For the first time, you may not be aware, but health providers, right, the doctor, right, Dr. Mwangangi, will actually be liable for participating in fraud through NHIF. So previously, we had either hospitals that would be sanctioned, and that's still there, or perhaps even any collaborators within the fund, that's still there. But for the first time, there's a recognition and a penalty. For me, myself,
For the
Mercy,
healthcare worker.
right, for prescribing or for attempting to have done 5 hip replacements in a week, or for doing a hysterectomy in a man. And that happens, I can tell you. So essentially, that's removing a uterus from a man. That happens. And so there's actually very tough penalties within, if you go through the finer print of the bill that is aiming to stop this process. The third thing is actually the auditing function when it comes to IT systems. So you've always had us talking about e-claim systems, and I think it would be nice for you to invite Dr. Kamunyo. He's the CEO of NHIF here. He has a lot of information to share with you guys. There's going to be an overhaul of that system to ensure that you're able to actually get a unique identifier. I'll tell you some of the cases of fraud that we see in NHIF is one card being used between sisters. Right, so you and I, we have one insurance card, and we are using it as if we are one family, right? So all those things are going to be dealt with, and Kamunyo will come and share with you all the many stories of things that we've unearthed within the fund. That's going to be super important because you'll have all the money in one pot. We need to secure the money. We need to secure those resources and ensure that they are available.
Right.
Now, the third thing that's really important is then the outcome. Remember, I talked about the outcome. You're trying to buy a service to ensure it has a good outcome. In terms of outcome, we have to ensure that when a Kenyan walks in, that they walk out happy, right? And so there's an element of quality of care. And NHIF is moving towards a process where they will pay, not just because you did a cesarean section, but you did a cesarean section that led to a good outcome. And that's different. And I think you've heard of this in the UK and in the NHS system where we will buy quality.
Yes.
We will pay for quality. We won't just pay for a service that you did. So for example, we were looking at audits of NHIF some time back, and we found out that there was a woman who had undergone a hip replacement about 3 times. That means there was failure on the doctor's work. That means there was failure on the hospital's work. But guess what? We paid. We ended up paying for each and every that procedure, for those 3 hip
Each of them.
replacements, right? So now what we'll do is we won't pay. We pay pegged on quality, pegged on outcome. And so these are big moves, again, that will change the space in healthcare. And what will happen is that there'll be a change in behavior from the providers. I think I've also seen lots of complaints on social media. You'll go to a doctor and you'll come out with a rap sheet of tests and procedures to do. And, and you're wondering, of course, there's information asymmetry. You don't know what I'm asking you to do. I could be trying to, get your DNA or sperm count or whatever. There's a reason, right? What we're going to be doing is putting in place systems of paying that actually bundle the tests. So NHIF will know if Mercy's diagnosis is diabetes, then this is a bundle of tests that would be required
goes
for
with
that.
that.
And
Not
that's
anything
what
outside of
exactly,
that.
exactly. So there's lots of controls that we're trying to sort of fashion and think through and put
Does
in
that happen
place.
in the private sector?
Yes, in
Private
fact, much
insurance.
more. Yes. In fact, much more than you'd expect in NHIF. I would love to sit here with Tony. That's Gishuri. He's from AKI, Association of Kenyan Insurers, and that whole team. And we've had discussions with them on how can we reduce leakage when it comes to medical insurance, not just in NHIF, but in Kenya, as a whole entity. And you'll notice that abuse. The issue with sisters sharing cards happens as well in private medical insurance. In fact, the insurance industry is one of the most, should I say, vulnerable industries when it comes to wastage and fraud. And so we are working with them, particularly through IRA, to try and see when you go, to seek a service, first, if you have a card that we all sort of have access to know, I have AR and Jubilee and NHIF. So that's going to be important when it comes to also how we pay the provider, right? So whose card comes in first?
Yeah.
Is it the NHIF card or is it your AR card? That's an important sort of conversation.
Yeah.
The second bit will then to reduce fraud, right? So if they're flagging fraud on their end, chances are it's also happening on our end with the same culprit. So we'll be able to share our information and data and have access to that. But then the most important thing is what you said. The fact that I can be Dr. Mwangangi, obstetrician, and MPSHA is, would charge 200 and another hospital and another and another and another. And I've not just used MPSHA because I'm branding for them. It is a good hospital. But anyway, have different costs of care. We'll be able to moderate that and try and get that together in terms of standardization of care. So that then if you want to go and have an extra service, so you want to have the big room that has a balcony, then you pay for that. But then we're able to take care of your basic service.
Yes.
Yeah.
Can we look at, when we talk about UHC now, a lot of us are in the situation whereby you get sick and what happens to be able to take care of that is contributions, Harambe's, etc., etc.
Yes.
So paint the picture of what it would look like when I have that card and I'm sick. It doesn't matter whether I am unemployed or whether I am at the other end of the spectrum. What does it mean then to have a card with what plans are in place and to walk into a medical facility and what will I have?
So it's absolutely powerful. I think you've one of the, should I say, most exasperating experiences is for a mother to get into labor and to need to rush to a hospital, right? And usually part of that includes I need to find transport to the hospital. I need to get myself there. I need to ensure I have everything that I need to deliver properly. The biggest mirror of what it would look like right now is the Linda Mama program. I'm sure you've all heard of the Linda Mama program.
Yeah.
When that program was put in place, for the first time as a mother, the concern of all the costs that you have to incur by the time you go in for a delivery are essentially not there. So you're walking in, and the Linda Mama program is universal, right? So it's any pregnant mother in the country who's not within the normal NHI formal systems is able to go in and get care in a healthcare facility. That has changed a lot. We've met mothers, we've done interviews with mothers who say, that was her first interaction with the healthcare system from the time of birth, because she was able to walk in and get the care she needed. And that's profound, guys. You and I are able to perhaps access health facilities easily for whatever check. You have a cold, you run there. You have some issue, you run there. For some of these Kenyans, this was their first interaction with the healthcare system. And that's what's going to change. So we actually have a huge number of Kenyans who do not interact with the system right now for all sorts of issues and even very serious diseases. Those guys will have access. The second thing is, I don't know if you know the pains of sitting through registration and having to remove some money from your pocket before you see a doctor. I've worked in a public facility. I know what it means to see someone sitting on a bench and they're trying to sort of count their shillings before they approach the casualty. That will change. Right? Now, another important thing, and you asked me this question earlier, what about the medication? Because of how we will bundle care in NHIF, because of how we will determine for diabetes, these are the tests and these are the meds, when you walk in, those costs are computed into the benefit package. And so you will almost have an assurance that if I go to a facility, I will get my metformin and my drugs that I need for my diabetes because it's bundled in the reimbursement that the provider will get. You get? Right?
Beautiful picture.
Right.
Reality. The reality of our government and very many things, like you said, it's a moving machine.
Yeah.
And then it has also been infiltrated by people who have various interests.
Right.
So those very many other interests that are coming in, how do you make sure that they do not interfere with this very beautiful plan? The other interests, the commercial interests, the cartels. You sit in that building that's now called Mafia House. I'm sure you've felt the heat from the mafia.
I would say it's I mean, Mafia House is perhaps one of the instrumental buildings within the country because dealing with people's healthcare is, I think, beyond then financing it. It's one of the most important functions of government. One, I can tell you through different interventions and through a larger move as government, there's a realization that you have to ensure you protect public goods. You have to ensure that systems are there for accountability and transparency. You have to ensure the individuals who manage these resources are accountable and are transparent. And so there's a lot going on beyond, let me say, the Ministry of Health to ensure that these processes are put in place, particularly through the court systems, particularly, again, through the bill. Like I said, for the first time now, we're actually targeting and going, for individuals who perpetuate fraud within the fund. That was never there before in the NHIF bill. So there's moves to ensure that, there's protection of what we're trying to do. I think another important component would be the citizen. I think right now we're having more, more voices heard in the citizenry. And that's always important for any nation that's developing. And as government, we continue to collaborate with particularly CSOs and citizens and communities to ensure that they're also at the table as we design those policies and as we implement them. Will it be easy? Certainly not. Are there challenges? I think we see them every day in the country. I think if you just look back a year from now, there have been challenges here and there all over. But for me today, like you said earlier, I'm optimistic. Like I said, I've been in the game now for 12 years, and I can tell you things are dramatically different than they were 12 years ago. And so it's optimism, and it's moving forward. And of course, then having those who are duty bearers like myself held accountable to ensure that we move this forward.
I've been quiet because I'm fascinated by what you're saying.
I like to fascinate.
But how do you legislate against greed?
Well, that's what you call it.
It's actually beyond the Ministry of Health. And that is how the multi-sectoral approach to this thing comes into being.
Yeah, that's important. Yep.
Because all these good plans will be in place. And then greed will rear its head.
I think, we've had those philosophical musings of how do we move our country forward? And if you look at some of the moves that are there right now that are trying to be put in place, it's about having some intrinsic reflection of who we are as Kenyans. And how do we move to this nirvana that we want to get to while still needing to recognize who we are as a people and what we need to change in our culture, in our behaviors. And so I think, like you said, it's beyond the ministry, but I think it's not necessarily just responsibility of government. It's the Kenyan. What are our ethos? What are our principles? How do we move to nirvana as Kenya? And what do I need to do individually? And what does government need to do? What do partners need to do? What does the civil society need to do to move forward? Yeah.
You can be a good preacher. You've converted CT. CT is sitting here thinking, this country, there's a future. There's a big future in this
No, but
country.
it is, guys. I can tell you, if I could sort of give you an insider view, things are changing. The wheel is moving. It's moving forward. It might be slow, but it's moving forward.
Taking big boss moves. We know that you have a meeting that you need to rush to, and we'll give you that.
Thank you.
So 5 minutes to the end of you can just give us the 5 minutes so we can conclude, right? Yeah. So in those 5 minutes, with the reality of things. So UHC, we had the pilot in the 4 counties.
Yep.
We have never seen the report of what happened in those 4 counties.
Right.
So that we can then now say, let's move it to the other 43 counties. What happened to those reports?
So there's a report, and I will send it to you on email. In fact, it's a report that we have discussed in so many forums. And in the last 2 weeks ago, we had what is called the Intergovernmental Forum. This is when all the governors come together with the Ministry of Health, and we sit and we discuss the health sector. And that report, again, was shared in that forum, not for the first time, but probably the 3rd, 4th time. And I think the biggest thing is there's actually a sub-report on lessons from the UHC pilot, right? So there's a pilot report, and then there's lessons from that UHC pilot. One of the lessons was, the pilot did meet an unmet need. We had, close to about 3.5 million Kenyans who were accessing that UHC package then. And we had, wait for it, a 40% increase in hospital visits within the first month of deployment of the pilot. So it means you had 40% inflow into the health facility. And so that told us for sure there's need to work on this UHC agenda and ensure Kenyans can get access to health services. On the flip side, while we were able to pump in resources through what we call input, so we took care of, is it medicines you don't have? You can get the medicines. Is it health workers that you don't have? There they are. So we were sort of pumping resources into the input side of things, hoping that we'll get a good outcome. We came to learn that we need to have a more sustainable mechanism, thus NHIF. So everything that we're doing now is essentially borrowing from all the lessons from the UHC pilot exercise. And that was almost 2-3 years ago. Interventions have been held since then. So we moved from the 4 counties to the 47, and we actually invested in more inputs in the 47 in an interim. And right now, the plan in terms of UHC is basically to use NHIF as the implementing agency for the UHC agenda. And then, of course, to still continue with investments in inputs. You still need that lab infrastructure working. You still need brick and mortar. You still need that healthcare work. Exactly. You still need, exactly.
How about the community health workers?
So again, super important. Yesterday, yesterday or the day before, Waziri launched together with the NMS team what we are calling the Community Health Volunteers Act for Nairobi. And that's a collaboration between the ministry and partners to ensure that the community health volunteers who will be working in Nairobi will be able to get a daily stipend that enables them to work. And during that activity, what he saw is that the community health worker is so pivotal. This is your neighbor, where you live. I'm not sure which suburb you live in, but the idea would be that my neighbor, your neighbor, would actually be able to interact with you and the health system and come and check, did you get vaccinated? If your wife is pregnant, has she been able to go for her ANC services? So they're super vital. And I think that's a front step for Nairobi County. As government, we do have a bill. It's in Senate. It's a community health volunteers bill in Senate, and I think Senate actually passed it through to ensure that these guys are, formally recognized in a manner where they're facilitated to do their work. Because it's not their full-time work. So this is someone who more or less gives hours of their day or their week to ensuring that their community is healthy. So super important as well.
Thank you very much. Dr. Mercy Mwangangi is the Chief Administrative Secretary in the Ministry of Health. One of the 5 women that we are featuring this week making big boss moves in government. Thank you very much for all your work you're doing in public service.
Thank you, guys.
That time when you came, it was so can we now say congratulations for all the good work that you're doing in the Ministry of Health?
Thank you. Always happy, to serve Kenyans, but also let me just thank you guys for highlighting the work that's being done in the ministry and also for calling us to be accountable. That voice is needed. Do not relent on that.
That we cannot do. Thank you very much.
This is The Situation Room, the only way to start your day.